That being said, let's make at least some comments on this chapter on minor abdominal trauma and pregnancy. How many of you get the Emergency Medicine Throwaway Journal? Years ago, there was an article in there which I read with fascination, and it was a street guide to emergency C-section and a dead woman on the street. Something we encounter all the time. And so this author is saying, you know what, you should commit yourself for the rest of your life to always wearing shoes with laces, so you'll have something to tie the umbilical cord off with. And you should have hard enough shoes or some hard object in your pocket so that you can break a nearby, or the scenario is and of course this would only happen in New York City, is you're walking down the street and suddenly there's this acutely decapitated 9-month pregnant woman right in front of you. So what are you to do? As opposed to what we normally do. So you got to wear the shoes with the laces. You got to have either hard shoes or hard objects. And hopefully this decapitated woman is lying near a car with a window that you can break. So now you have glass, something sharp that you can do to. I didn't understand. I seriously didn't understand from the article why he didn't just recommend carrying a knife with you instead of carrying hard objects to break windows so you can use the glass as a knife. I guess it's sexier that way. So he described this whole thing about how to do an emergency C-section using easily obtainable tools in the street. The only proviso is hard to find a shoelace, so you got to bring your own. So. What are we doing with women who present to the emergency department who appear to have minor trauma? With major trauma, our OB people have been absolutely adamant is that you focus on the mother, and if you have to forget the infant to focus on the mother, forget the infant. Get them down right away, consider emergency C-section and this sort of thing, but all the focus has to first go to the mother. So they first come to the emergency department and we do our magic. And there's a little talk in here about what we do, and then at our institution, then we send them up to OB. OB, to me, is a model for what inpatient units should be like. If you have an ICU admit and the ICU is full, what happens to the patient? They're board in the ER. If you have a medical admit, a chest pain admit, and there's no beds on the inpatient unit, they're board in the ER. If you have a woman about to deliver a baby, and they're full on L&D, do they board in the ER? No, they take them. They own the problem. So God bless OB. They're the model that I think everybody else should follow. So number one looks at what we are doing, and this is really a survey from residency directors, so this may be very different than community hospitals. But the punchline is that the woman first gets evaluated in the emergency department, and then everything other than the most obviously trivial type of injuries or highly localized extremity injury or something will go up to L&D, and they will typically monitor for 4 to 6 hours, and in some places 24. So what should we do? There's no randomized prospective study which can give us this answer. There's some guidelines out there about what to do, and the main one being monitor for at least 4 hours. Some debate whether you should do 6. There's a wonderful study by Perlman of a fairly large number of patients where their punchline was, if nothing's happened at the end of 4 hours, nothing's going to happen in the next 24. So you can safely send the patient home. And if they have any contractions during that period of time, then you monitor them for the full 24 rather than just the first 4. One of the problems that has come up in the evaluation, one of the big issues that comes up in a woman who's pregnant with minor trauma is whether they have some early detachment of the placenta. So we would, I guess, all think that ultrasound will give you the answer to that question. And unfortunately, it clearly doesn't. In the article of Cahill, this is number 2, I think. Yeah. There's 317 females, at least 24 weeks. And what do they get? They get a physical exam, ultrasound, amniotic fluid index, fetal weight and position, 4 hours of monitoring, labs with fibrinogen and Kleihauer-Becky test. And in this group that was studied, 20% of the women had an adverse outcome related to their pregnancy. And so then Cahill asked, well, which of all these tests, other than monitoring, helped us to pick out the one that would get in trouble, and where we could safely say, well, if this test is normal, you don't have to worry about the woman. The most sensitive test was the highest sensitivity was 42%. The lowest was 2%. So the conclusion was very clear from this study that there's no simple lab test that you can get that gives you the answer, and ultrasound can't give you the answer. If you're worried about the trauma, you have to monitor. There's no other way around this. So that, I think, is a nice, clear answer to the question, is there anything we can get short of monitoring? And it seems like the answer is negative. How many of you will order a Kleihauer Becky on trauma patients, women with trauma? How many don't? How many of you have herpes today and can't raise your hands? Okay. These are two different studies, number 3 and number 4, both looking at women with pregnant with trauma, and both looking at how good the Kleihauer, the KB test is. In the first study, it was positive 100% of the time. In the second study, it was hardly ever positive, and it was actually positive twice as often in the women with no trauma than the women with trauma. So that was a rather humorous result. How could you get such widely divergent results? Well, the first article is a trauma registry. How do you get in a trauma registry? You get in a trauma registry because you've had trauma that's bad enough that the surgeons had to come down and admit you and put you in their registry. So this, by definition, is a select group of people. And it seemed in those circumstances, of the 46 women who had a problem, or 46 patients with positive tests, 44 had a problem with premature labor or uterine contractions. Now, so it may work in major trauma. Or the other thing may be that you pay a lot more attention to people with a positive test, so you pick up a lot more stuff and you document it in the chart because you're expecting it, so you're watching for it. That certainly is the other possibility for that study. But 4 I thought was rather funny because it sort of concludes if you read those results, then you would use the KB test to exclude significant issues in women with minor trauma. And remember, all of these women, in the circumstances of minor trauma, particularly if they are admitted or they have a positive KB test, if they're Rh negative, which about 15% of the population is, they all get RhoGAM. So how are we actually doing at giving RhoGAM? So if we do that study, what do you think the results would show? Okay, here, let's make some guesses. Option 1, we're doing perfectly. Option 2, except for this person in the back row in the corner there, we're doing perfectly. And option 3, we're really as loose as a goose on this stuff. So option 3 ends up being the correct answer. But at least we're internally consistent. And it appears that step 1, which is to check their Rh status, we don't do. And by not doing that, we don't have to worry about step 2, which is to give RhoGAM to those mothers that are Rh negative. The author here of the chapter makes a point which I think is interesting. I don't know if any of you have read any literature on this. I've never seen any literature on this. The initial development of RhoGAM is the problem's not with the baby you have, it's the problem with the next baby. You're an Rh negative mom, you got an Rh positive baby, so now with your next with your next, boy, that was a slip, with your next baby, then you have presented that you've become sensitized, and so now you get fetal high drops. No one has ever studied, as far as I know, or certainly I've never read, what's the impact on an Rh positive fetus that you have right now giving RhoGAM? Does it do, because it will cross the barrier, and does it cause any hemolysis or low-grade hemolysis or anything else? Does it make them go to Yale instead of Harvard or these sort of things, I guess, need to be studied? Anybody familiar with any studies that look at the effect on the baby that's there now? No? Okay. And the last article in this section, this is a short chapter, so we may all have to get up and go to the bathroom or something, is seat belts. Here's another study that asks the following thing that we will have a hard time guessing what it is. Question number 1, do pregnant women regularly, always wear seat belts? And question number 2, does every pregnant woman at least know how they should wear seat belts? And as you can guess, typically for all of these sorts of studies, the answer is, who knows? Or the answer is no. A lot of women don't know the proper use of seat belts, and a lot won't wear it because they think it's a danger. Actually, that's what I just made a misstatement, not a lot. The minority of women will not use seat belts, and they will use it incorrectly, but the majority actually do. So in terms of evaluating minor trauma in pregnant patients, I have a question. How many of you work in places where you don't have L&D? So how do you manage these patients? Stabilize and transfer? Okay. And that includes, now for very minor trauma where otherwise you'd absolutely clear them, do you send them by ambulance or just ask them to drive in a car over to the other hospital or what? Send them by ambulance? Okay. And any mishaps with that you want to confess on the camera that's going to be on the internet? What's the name of your institution? It's, all right, well, that's that. Everybody, why don't you just run to the bathroom, grab some food, and then Kevin will be in here with the next section.